Welcome to the Deep Dive, where we get straight to the fascinating stuff. You're here because you want to understand complex topics quickly, without getting lost in the weeds. That's exactly what we deliver.
Today, you're in for a really interesting exploration into developmental disorders. We've gathered some excellent material on these conditions, and what's particularly striking is how often these developmental differences manifest in the oral and dental areas.
Exactly. So, our mission is to extract the core knowledge about specific developmental disorders, paying close attention to how they impact the face and mouth. Okay, let's dive right in with a condition called cherubism. It has a gentle name, but it's a hereditary condition that affects the jaws.
What's intriguing right from the start is how it's passed down. Cherubism follows an autosomal dominant inheritance pattern. Think of it like, having two copies of most genes, one from each parent. If the gene for cherubism from just one parent is present, the child will likely develop the condition.
Okay.
And it tends to show up more in males, about twice as often as in females.
Now, the key thing you'd notice is a symmetrical, painless swelling in the lower part of the face in young children, usually under the age of 5.
Right.
Because of this fullness in the cheeks and jaws, it can actually push the eyes upwards, giving a characteristic upward-gazing appearance, which is how it got its name, I guess.
Exactly. If we look at the specific bones involved, the swelling typically affects the angle of the mandible, that's the corner of your lower jaw. The ascending ramus, which goes upwards toward your ear, the retromolar region behind your back teeth, and the posterior part of the maxilla, your upper jaw. Interestingly, while it's usually on both sides, the mandible is the most frequent site.
So what's actually happening in the bone to cause this swelling?
Yeah.
Is it extra bone growth or?
Well, the fundamental issue is a process called bone resorption, where existing bone tissue is broken down. In cherubism, this bone is then replaced by fibrous tissue.
Oh, okay.
This fibrous tissue expands within the bone, leading to that noticeable swelling.
And I imagine this looks quite distinct on an X-ray.
It does. Radiographically, cherubism has a really characteristic soup bubble appearance.
Soup bubble.
Yeah. This is due to multiple well-defined dark areas, we call them multilocular radiolucencies within the jaws, separated by thin walls of bone, or bony trabeculae. You might also see teeth that haven't erupted yet appearing to sort of float within these cyst-like spaces.
That's a very descriptive image. Wow. Now, is this a condition that persists throughout life?
Interestingly, cherubism often has a self-limiting course. It can start to regress around the time of puberty, and there can be significant resolution, even a near return to normal, by about age 30.
Really? By 30?
Yeah, though we should note we don't have extensive long-term studies on this spontaneous resolution.
Right. And if you were to look at this tissue under a microscope, what would you see? Like, what's characteristic?
Histologically, the lesions are characterized by a highly vascularized fibrous stroma that's a connective tissue framework with lots of blood vessels containing numerous multinucleated giant cells.
Yeah.
These are large cells with multiple nuclei, and they're a key feature, though they appear in other conditions as well. In more mature lesions, you tend to see more fibrous tissue and fewer of these giant cells.
Okay.
Another distinctive finding is the eosinophilic perivascular cuffing of collagen, which is a specific pattern of collagen fibers around small blood vessels that stains pink with a certain dye.
Got it. Okay, so while it often resolves on its own, what about treatment in the meantime, if it's causing issues?
Treatment is primarily focused on improving function, preventing any functional impairments, and addressing any aesthetic concerns that might arise. Surgery might be considered based on these individual needs,
Okay, that makes sense. All right, let's shift gears to a condition that sounds quite different. Osteopetrosis, also known as Albers-Schoenberg disease.
Osteopetrosis. Yeah, this one's a rare hereditary condition where the bones become abnormally dense. It's a generalized and symmetrical increase in skeletal density.
So dense bones, why does that happen?
It happens because of a defect in bone resorption. Those bone remodeling cells called osteoclasts aren't functioning properly, even though there might be a normal or even increased number of them.
So instead of bone being broken down and replaced in that normal cycle, it just keeps getting denser and denser.
Exactly. This reduced activity of the osteoclast leads to an accumulation of bone mass, causing skeletal disturbances. The bones become very hard, almost like marble, which is what petrosis refers to, like stone.
Wow.
The gene often involved is the one that codes for granulocyte macrophage colony stimulating factor, or GM-CSF, which plays a role in the development of osteoclasts.
And what kind of problems does this increased density actually cause for someone? It sounds like stronger bones might be good, but maybe not.
Well, bone pain is a common symptom. But because this overly dense bone can compress nerves, particularly the cranial nerves that control things like sight, hearing, and smell, you can see some serious issues,
Hmm.
such as blindness, deafness, loss of the sense of smell and taste, and even facial paralysis.
Hmm.
Imagine these delicate nerves being squeezed by bone that's become too thick.
That sounds quite severe. And what about the bones themselves? Are they actually stronger because they're denser?
Ironically, no. The bone that forms in osteopetrosis, while dense, is actually poorly structured and more brittle,
Ah,
making it fragile and prone to what we call pathologic fractures, fractures that occur much more easily than they would in normal bone.
okay. And how does this impact the oral cavity? You mentioned oral manifestations are common.
Yeah, the dental findings are quite significant. You might observe a delay in the eruption of teeth that are congenitally absent, meaning they never formed, unerupted and malformed teeth,
Oh,
and a condition called enamel hypoplasia, where the enamel, the hard outer layer of the tooth, doesn't develop properly. There can also be decreased formation of the alveolar bone that supports the teeth, a thickening of the periodontal ligament, the tissue connecting the tooth to the bone, and mandibular prognathism, where the lower jaw juts forward.
and does that enamel issue cause other problems?
Yes, that enamel hypoplasia also makes individuals with osteopetrosis more susceptible to dental caries or cavities.
Right, right. And I remember reading something about a serious complication related to infection.
Yes, osteomyelitis, which is a bone infection, is a significant risk, especially in the mandible, although it can occur in other bones as well.
Why is that?
The impaired bone remodeling in osteopetrosis makes it difficult for the body's immune system to effectively fight off infection within the bone. It's like the infection gets trapped.
Oof. Okay. What does osteopetrosis look like on an X-ray? You mentioned the cherubism soap bubbles.
Right. Radiographically, osteopetrosis has a classic bone-within-bone
A
appearance.
bone within bone.
Yeah, it occurs because of the disrupted way the long bones remodel as they grow. You also see a generalized increase in the overall density of the skeleton, and you might lose the clear distinction that's normally visible between the dense outer layer, the cortex, and the inner, more spongy bone, the medulla.
Interesting. And histologically, under the microscope, what's the key finding?
A biopsy of endochondral bone, which is bone that replaces cartilage during development, will show a core of calcified cartilage that's surrounded by bone matrix. This reflects the underlying problem in the normal process where cartilage is gradually replaced by mature bone.
Okay. I understand there are different forms of osteopetrosis varying quite a bit in severity.
That's correct. It's broadly categorized into three main clinical groups. The infantile malignant form is inherited in an autosomal recessive pattern, meaning 2 copies of the faulty gene, one from each parent, are needed.
Okay.
And unfortunately, it's typically fatal within the first 2 to 3 years of life if not treated.
Well, that's severe.
Then there's the intermediate form, also autosomal recessive. It's non-fatal but more aggressive, usually presenting within the first decade of life. And then there's the autosomal dominant form, which is the least severe. Individuals with this form often have a full life expectancy, but can experience significant health issues related to orthopedic problems like fractures. But sadly, in the more severe forms, death can result from secondary infections or anemia due to the reduced space in the bone marrow where blood cells are produced.
That's a really wide spectrum of severity. Okay, let's move on now to osteogenesis imperfecta, which is often referred to as brittle bone disease.
Osteogenesis imperfecta, yes. It's actually a group of heritable connective tissue disorders estimated to occur in about 1 in 20,000 births.
Okay.
The hallmark features are bones that fracture very easily, blue sclerae, the whites of the eyes have a bluish tint,
I've heard of that.
increased laxity in ligaments, hearing loss, and sometimes dentinogenesis imperfecta, which affects the normal development of dentin, the main tissue of the tooth.
And what's the fundamental cause of this fragility? Why are the bones so brittle?
The vast majority of cases are caused by mutations in the genes that provide the instructions for making type 1 collagen, specifically the COL1A1 and COL1A2 genes.
Collagen, okay.
Yeah, collagen is a really crucial protein that provides structure and strength to many tissues in the body, including bone. So if that's faulty, the bones are weak.
Makes sense. You mentioned there are different types of osteogenesis imperfecta.
Yes, there are several types, each with varying degrees of severity. Type I is the most common and generally the mildest form. It's characterized by osteoporosis, leading to bone fragility and fractures, those blue sclerae, and often a type of hearing loss called conductive hearing loss that may develop in adolescence or adulthood.
Okay.
Individuals with type I might also be slightly shorter than average, and sometimes they have dentinogenesis imperfecta.
And the other types?
Type 2 is the most severe form, often lethal in the perinatal period, and is usually inherited in an autosomal recessive manner, although it can also arise from new dominant mutations. Infants with type 2 often have low birth weight, short stature, and severely deformed limbs.
Oh, wow.
Type 3 also presents with significant bone fragility and multiple fractures from birth, as well as progressive skeletal deformities. Interestingly, while the sclerae are blue at birth, they tend to become lighter and may even appear normal with age. Finally, type 4 is a dominantly inherited form that is characterized mainly by osteopenia, a lower than normal bone density and bone fragility, but typically without the other classic features like blue sclerae or dentinogenesis imperfecta.
So, a very diverse range of presentations. Is there a specific treatment available? A cure?
Unfortunately, there's currently no cure for osteogenesis imperfecta. However, medications called bisphosphonates, which help to increase bone density and reduce the risk of fractures, are often used to manage the condition.
Right. Management, not cure. Okay, let's move on to another fascinating condition. Cleidocranial dysplasia, or CCD.
Cleidocranial dysplasia. This one is particularly notable for the underdevelopment or complete absence of the clavicles, your collarbones.
No collarbones.
So very underdeveloped ones, yeah. Along with characteristic changes in the skull and face and the presence of numerous extra teeth, which we call supernumerary teeth, as well as teeth that fail to erupt properly.
Wow. What's the genetic basis for CCD?
It's usually passed down through families in an autosomal dominant pattern, meaning if one parent has the gene, there's a high chance it will be passed on. It has what we call high penetrance, meaning most people who inherit the gene will show some features.
Okay.
But the expressivity, how severely those features manifest, can vary quite a bit from person to person. In very rare cases, a recessive inheritance pattern has also been reported.
And the gene?
The gene responsible is RUNX2. It's a transcription factor, basically a protein that helps regulate the activity of other genes, and it plays a critical role in the development of both bone and teeth.
Gotcha. What are some of the key clinical signs that might suggest CCD, besides the collarbone thing?
Well, individuals with CCD often have mild to moderate short stature, and their neck can appear longer and narrower than usual because of the abnormalities in the shoulders. The shoulders themselves are often noticeably drooped.
Right.
And because the clavicles are underdeveloped or absent, they have increased mobility in their shoulder joints. Some individuals can even bring their shoulders together in front of their chest.
Right.
The head tends to be larger than average and brachycephalic, meaning it's wider and shorter from front to back, with prominent bossing of the forehead, parietal bones on the sides of the head, and the occipital bone at the back.
Okay.
The bones of the face and the paranasal sinuses are often hypoplastic, meaning underdeveloped, leading to a face that appears small and short, particularly with an underdeveloped maxilla, the upper jaw. They often have a broad-based nose with a flattened or depressed nasal bridge, and ocular hypertelorism, which is an increased distance between the eyes.
And you mentioned significant dental issues are a hallmark of CCD. That sounds pretty major.
Absolutely. The roof of the mouth, the palate, is often narrow and highly arched, and there's a higher likelihood of cleft palate. Due to the underdeveloped upper jaw and a lower jaw that's typically of normal size or even slightly larger, they often have mandibular prognathism, where the lower jaw protrudes.
Okay.
But a very characteristic feature of CCD is the prolonged retention of the primary or baby teeth, failure of the permanent teeth to erupt, and the presence of numerous supernumerary teeth, sometimes dozens of them.
Dozens. Wow.
Yeah. All of this contributes to severe malocclusion, or a bad bite.
What do x-rays typically reveal in someone with CCD then, besides the missing clavicles?
Skull x-rays often show fontanelles, those soft spots on a baby's head that remain open much longer than they normally would, as well as the presence of Wormian bones, which are small, extra bones within the sutures, the fibrous joints between the skull bones.
Wormian bones, okay.
The cranial sutures themselves can appear wider than normal and have an unusual pattern. The paranasal sinuses are often underdeveloped or even absent. And, of course, x-rays of the jaws will reveal the presence of many unerupted, permanent, and supernumerary teeth, often in very unusual positions.
Is there a way to specifically treat cleidocranial dysplasia, fix the underlying issue?
Unfortunately, there's no specific cure for CCD. Treatment focuses on managing the various symptoms and issues that arise. This often involves orthognathic surgery to correct the jaw and facial deformities, orthodontics to address the complex malocclusion, and help bring the permanent teeth into their correct
Right,
positions.
dealing with all those extra teeth.
Exactly, and the use of prosthetic devices to replace any missing teeth. It's a complex, long-term process.
Now let's move on to Cruzon syndrome, also known as craniofacial dysostosis.
Cruzon syndrome. This one's characterized by noticeable deformities of the skull and face, specifically maxillary hypoplasia, meaning an underdeveloped upper jaw, and shallow eye sockets that can lead to exophthalmos, or protrusion of the eyeballs.
Okay.
The particular skull deformity varies depending on which of the cranial sutures fuse prematurely, a process called premature synostosis, with the coronal suture being the most commonly affected.
And what is the underlying cause of this early fusion? Why does that happen?
It's typically inherited in an autosomal dominant manner and is caused by mutations in the fibroblast growth factor receptor family of genes, specifically FGFR1, FGFR2, and FGFR3. These genes play important roles in bone development.
FGFR genes, okay. What are some of the telltale clinical signs that might indicate Cruzon syndrome?
An increased distance between the eyes, which is called hypertelorism, and exophthalmos are fairly constant features and often become apparent in early childhood. Sadly, there can also be systemic complications in some cases, such as intellectual disability, hearing loss, speech and visual impairments, and even seizures.
Oh, wow. So it can affect more than just the skull and face.
It can, yeah.
Yeah.
And what about the characteristic facial appearance associated with Cruzons?
Individuals with Cruzons often have a distinctive facial appearance, sometimes described as frog-like.
Frog-like.
Yeah, largely due to the mid-face hypoplasia and the protruding eyeballs. They tend to have what we call relative mandibular prognathism, meaning the lower jaw appears more prominent because the upper jaw is underdeveloped, a nose that's sometimes described as resembling a parrot's beak, a short upper lip and philtrum, that little groove above your upper lip, and the lower lip often appears to droop.
Okay, and how does Cruzon syndrome affect oral health specifically?
The severe underdevelopment of the maxilla leads to a narrow upper dental arch and a compressed, high-arched palate. Bilateral posterior lingual crossbites are very common, where the upper back teeth bite inside the lower back teeth.
Right.
Because the upper jaw is positioned more inferiorly, lower down, it can cause a premature contact of the back teeth, leading to an anterior open bite, where the front teeth don't meet when the back teeth are closed.
Are there any specific findings on skull x-rays for Cruzon syndrome? Something characteristic like the others?
Yes, skull radiographs often show the premature fusion of the cranial sutures, with obvious bony bridging across the suture lines. A very characteristic finding is the hammered silver or beaten metal appearance of the inner surface of the skull.
Beaten metal?
Yeah, which is thought to be due to increased intracranial pressure early in development affecting the bone formation.
Huh. Okay. How is Cruzon's syndrome typically managed?
Surgical intervention may be necessary if the exophthalmos is severe or progressive, or if there's a risk of damage to the optic nerve and impaired vision. Orthodontic treatment, often followed by orthognathic surgery to reposition the jaws, is usually very helpful in managing the dental and facial deformities.
Makes sense. Let's move on now to Treacher-Collins syndrome, also known as mandibulofacial dysostosis.
Treacher-Collins syndrome, okay. This generally presents bilaterally, affecting both sides of the face, and is characterized by a distinctive facial appearance.
What kind of appearance?
Includes downward sloping of the palpebral fissures, that's the opening between the eyelids colobomas, which are notches or gaps of the lower eyelids, and underdevelopment or hypoplasia of the mandible and midface.
Okay. What's the genetic basis for Treacher-Collins syndrome?
It's typically inherited in an autosomal dominant manner, and the primary genetic link is thought to be mutations in the TCOF1 gene. This syndrome is considered to arise from developmental abnormalities occurring in the first and second branchial arches, which are structures in the developing embryo that give rise to many of the bones and tissues of the face and neck.
Ah, the branchial arches. Okay. What are the key clinical findings that might lead to a diagnosis of Treacher-Collins?
Besides the characteristic facial features we've already mentioned, there's often varying degrees of hypoplasia affecting the mandible, the maxilla, the zygomatic process of the temporal bone part of your cheekbone area, and the external and middle ear.
The ears, too.
Yeah, the ears are frequently low set and can be malformed, sometimes even absent. And conductive hearing loss, a problem with sound transmission in the outer or middle ear. is common.
And what about the oral manifestations in Treacher-Collins syndrome? Anything specific there?
Cleft palate occurs in a significant percentage, around 30%, of individuals with Treacher-Collins. Macrostomia, an abnormally large mouth opening, is seen in about 15% of cases. They often have a high-arched palate. And dental malocclusion is common, characterized by teeth that are widely spaced and displaced. Severe hypoplasia of the mandible is a very characteristic feature.
Right, the small jaw.
And the zygomaticomaxillary complex, the midface region involving the cheekbones and upper jaw, is often significantly underdeveloped, leading to a noticeable midface deficiency. The condyle and coronoid processes of the mandible, which are important for jaw movement, can also be flattened or even absent.
Wow. How is Treacher-Collins syndrome typically treated then with all those different issues?
Treatment usually involves a series of surgical corrections and reconstructions performed over time, often requiring multiple surgeries throughout childhood and adolescence to address the various aspects of the condition as the individual grows and develops.
With a long process.
Very much so. The timing of these interventions is often carefully planned.
Now let's discuss Pierre-Robin syndrome, sometimes also referred to as Pierre-Robin sequence. What's that about?
Pierre-Robin syndrome is characterized by a specific triad of features that are present at birth. Micrognathia, which is a very small lower jaw. Glossoptosis, where the tongue is displaced backwards and downwards, often obstructing the airway.
Tongue falling back.
Exactly. And a high-arched or cleft palate. The primary underlying issue is generally considered to be the retrognathia and hypoplasia of the mandible, meaning the lower jaw is both small and set back.
Okay, so the small setback jaw is the main thing driving the other two.
Pretty much.
Yeah.
How does this combination of features typically present in newborns? It sounds serious.
Infants with Pierre-Robin typically exhibit severe micrognathia, glossoptosis with the tongue prolapsing towards the back of the throat, a cleft palate which often has a distinctive U shape, and as a direct consequence of the small jaw and the displaced tongue, they often experience airway obstruction that can range from mild to potentially life-threatening.
Wow. What's the exact connection between the small jaw and the tongue falling back, the glossoptosis?
Well, the glossoptosis occurs because the small and retruded mandible doesn't provide adequate forward support for the tongue. The genioglossus muscle, which is attached to the tongue and the front of the mandible, is also positioned more posteriorly, causing the tongue to fall back and potentially block the airway.
Right.
Additionally, the geniohyoid muscle, which helps to support the hyoid bone and the strap muscles of the larynx, can also be compromised due to the abnormal position of the mandible.
It sounds like managing breathing and feeding in newborns with Pierre-Robin is absolutely critical then, like #1 priority.
It is. Respiratory distress and feeding difficulties are the most immediate and significant concerns in the postnatal and neonatal periods. These infants often require constant medical supervision and sometimes interventions to maintain a clear airway and ensure adequate nutrition.
But is there any good news? Does it improve?
Yes, actually. What's really encouraging is that the mandible often undergoes a remarkable period of growth in the first 4 years of life.
Oh, really?
Yeah, and many individuals with Pierre-Robin achieve a relatively normal facial profile by the time they are 4 to 6 years old.
That's fascinating to hear about that potential for significant improvement with age. That's quite hopeful. Okay, let's move on now to Down syndrome, also known as trisomy 21. Most people have heard of this one.
Right. Down syndrome is a genetic condition that occurs when an individual has an extra copy of chromosome 21. This can arise due to various events during the formation of the egg or sperm or during early embryonic development.
And clinically, what are the key features?
Clinically, all individuals with Down syndrome exhibit some degree of intellectual disability, which varies in its severity. They often share certain physical characteristics, such as a skull that tends to be brachycephalic, meaning it's wider and shorter, almond-shaped eyes with upward slanting palpebral fissures, and epicanthic folds, those small folds of skin on the inner corner of the eye.
Okay.
Congenital heart disease is also very common, occurring in a significant proportion of individuals with Down syndrome, and they tend to be more susceptible to respiratory tract infections.
And what are some of the oral features that are frequently associated with Down syndrome? We see that quite a bit.
Yeah, the tongue often has deep grooves or fissures, and while there might be the appearance of macroglossia, a large tongue, due to the relatively smaller oral cavity, true macroglossia can also occur. An open mouth posture is quite common, often related to a high-arched palate that has a reduced width.
What about cavities? Is that risk higher?
Interestingly, despite some common misconceptions, the incidence of dental caries or cavities doesn't seem to be inherently higher in individuals with Down syndrome compared to the general
Oh,
population.
really?
Although maintaining good oral hygiene can certainly present more challenges. However, they do have a significantly increased risk of periodontal disease or gum disease.
Gum disease. Why is that?
It's linked to defects in their immune system and the function of neutrophils, a type of white blood cell that fights infection.
Okay, that makes sense. Are there any other characteristic dental findings in Down syndrome?
Yes, the eruption of both the primary and permanent teeth is often delayed. Hypodontia, meaning having fewer teeth than normal, is seen in both sets of teeth. And microdontia, where the teeth are smaller than normal, is also frequently observed.
Okay.
Malocclusion, or a misaligned bite, is very common and can be characterized by relative prognathism, where the lower jaw appears more prominent, posterior cross bites, or the upper back teeth bite inside the lower back teeth, often due to the smaller maxillary basal bone,
Right.
and anterior open bites, where the front teeth don't meet when the back teeth are closed. This anterior open bite is usually due to discrepancies in the alignment of the teeth and the surrounding alveolar bone rather than an underlying skeletal jaw issue. Severe crowding of the anterior teeth is also a very common finding.
So how is dental care typically approached for individuals with Down syndrome, given the higher risk of gum disease and the crowding?
Dental therapy for individuals with Down syndrome places a strong emphasis on the prevention of both dental caries and especially periodontal disease. Frequent and regular dental checkups, along with the establishment of very consistent and thorough oral hygiene routines at home, are absolutely critical.
Yeah, prevention is key there.
Hmm.
Now, let's turn our attention to two rarer conditions. Hemifacial atrophy and hemifacial hypertrophy, kind of opposites.
Pretty much. Hemifacial atrophy, also known as Perry-Romberg syndrome, is a rare disorder characterized by a progressive and gradual wasting away or atrophy of one side of the face.
Just one side?
Yeah, affecting both the soft tissues like skin and fat, as well as the underlying bone. The exact cause remains unknown, but various factors such as prior trauma, dysfunction of the sympathetic nervous system, or even infection have been suggested as potential triggers. It typically becomes noticeable during young adulthood.
Okay, and oral manifestations.
In terms of oral manifestations, the tongue, lips, and salivary glands on the affected side may show signs of atrophy, and developing teeth on that side can sometimes exhibit incomplete root development and delayed eruption. It's also worth noting that in some cases, other organs and systems on the same side of the body can also be involved.
Okay. And hemifacial hypertrophy is essentially the opposite of that, right? Overgrowth instead of wasting.
Exactly. Hemifacial hypertrophy is also a rare disorder characterized by an abnormal overgrowth and noticeable asymmetry of the body, typically affecting one side. Several potential underlying causes have been proposed, including abnormalities in the vascular or lymphatic systems and endocrine dysfunction.
And the dental findings.
When it comes to dental findings on the affected side, you might see teeth that are abnormal in their size and shape, both in the crown and the root. Malocclusion is common due to the asymmetric growth of the maxilla, mandible, and the alveolar process that supports the teeth, as well as abnormalities in tooth morphology and eruption patterns.
So the bite would be off.
Yeah, this can lead to a shift in the dental midline, severely tilted occlusal planes, the biting surfaces of the teeth, and open bites. Craniofacial findings can include asymmetry of the frontal bone, enlargement of the mandible, macrognathia, enlargement of the condyle, which is part of the jaw joint, and an increase in the size of the soft tissues on the affected side.
Got it. Finally, let's delve into cleft lip and palate, which you mentioned earlier is a more commonly encountered congenital anomaly.
Yes, clefts of the lip and palate are indeed among the more common congenital anomalies, and they can result in significant functional problems affecting speech, chewing, and swallowing.
How are they classified?
They are broadly classified into four main categories: cleft lip only, cleft palate only, unilateral cleft lip and palate affecting one side, and bilateral cleft lip and palate affecting both sides. The reported incidence is around 1 in every 700 to 1,000 live births.
So, fairly common, relatively speaking. What exactly happens during embryonic development that leads to these clefts? Like, when does it go wrong?
Cleft lip typically occurs relatively early in pregnancy, around the 6th to 7th week in utero. It's due to a failure of the tissues in the developing face to fuse properly.
How so?
Specifically, there's a failure of the epithelial groove between the medial and lateral nasal processes to be penetrated by mesodermal cells, which is a necessary step for complete fusion.
Okay. And the palate?
Cleft palate occurs a bit later, around the 8th week of gestation. It results from an epithelial breakdown and a failure of the mesodermal tissue to grow inwards and allow for the fusion of the lateral palatal segments, which normally come together to form the roof of the mouth.
And it can vary a lot in how severe it is.
Absolutely. The severity of both cleft lip and cleft palate can vary considerably, ranging from a very mild notch in the lip to a complete bilateral cleft that involves the lip, the alveolar ridge, where the teeth are, and the entire palate, both hard and soft.
Are there specific dental implications that are frequently seen in individuals with cleft lip and palate,
Mhm.
besides the obvious gap?
Yes, there's a higher incidence of congenitally missing teeth, particularly the maxillary lateral incisors. Those are the teeth right next to the central front teeth in the upper jaw and are often located adjacent to the cleft.
Okay.
The likelihood of having missing teeth, or hypodontia, tends to increase with the severity of the cleft. Interestingly, complete clefts can also be associated with the presence of supernumerary teeth, again, often in the region of the maxillary lateral incisors.
So missing teeth or extra teeth near the cleft.
Can be either, yeah. Tooth formation in the area of the cleft is frequently delayed, and you can also see enamel hypoplasia, as well as teeth that are either smaller than normal, microdontia, larger than normal, macrodontia, or even fused together.
Wow, lots of potential dental issues. And I know that treatment for cleft lip and palate is often a very long and coordinated process. It takes a village, right?
Absolutely. Treatment is typically a staged, multidisciplinary approach, meaning it involves a team of specialists working together over many years due to the wide-ranging impact of these conditions.
What's the typical timeline?
Surgical repair of the lip, known as chiloplasty, is usually performed around 3 months of age. Palatoplasty, the surgical repair of the cleft palate, is typically done around 9 months of age. If there are any remaining defects in the hard palate, these might be addressed later, usually between the ages of 7 and 9 years.
And later on.
Orthognathic surgery to correct any discrepancies in the jaw relationship might be necessary after palate growth is complete. Additional secondary corrections to improve function and aesthetics can be performed later in adolescence. And rhinoplasty, surgery to refine the appearance of the nose, might be considered after around 17 years of age.
It definitely sounds like a very carefully orchestrated effort involving many different types of medical professionals over a long time.
It is indeed. And just to briefly clarify the different types of cleft lip based on their embryological origins.
Yeah.
A median cleft lip is a very rare occurrence that results from the failure of the two medial nasal prominences to merge properly. A unilateral cleft lip, which is much more common, occurs when the maxillary prominence on one side fails to merge with the ipsilateral medial nasal prominence, and a bilateral cleft lip arises when the maxillary prominences on both sides fail to meet and unite with the respective medial nasal prominences.
Got it. This has been an incredibly comprehensive overview of a really diverse set of developmental disorders. It's truly fascinating to see the intricate ways in which genetics can influence these clinical outcomes, especially as they manifest in the oral and dental regions.
Yeah, what's particularly insightful is how these conditions, while often individually rare, collectively underscore the delicate and complex processes involved in human development and, the wide range of potential consequences when those processes are disrupted at various stages.
Right. So considering the self-limiting nature of some conditions like cherubism, and that remarkable potential for improvement we talked about in Pierre-Robin syndrome as children age, it really makes you wonder, what does this tell us about the body's inherent capacity for self-correction and adaptation, even in the face of these developmental challenges? It's definitely a powerful concept to consider.
It really does raise a fundamental question about the plasticity of human development and the intricate biological mechanisms that can sometimes compensate for initial developmental differences over time. It highlights that our genes are just, well, one part of the story, isn't it?
Absolutely. If any of these conditions have particularly sparked your curiosity, we really encourage you to use this deep dive as a starting point for your own further exploration. Thanks so much for joining us.